patient has, we need to calculate some numbers. So let's start. So what would the WHO recommendation on the antenatal steroid? So which are the sentences are correct? So the option number A is intramuscular dexamethasone, total 24 milligram in divided dose is recommended the antenatal corticosteroid of choice when the preterm birth is imminent. B. A single repeat course of antenatal steroid is recommended if the preterm birth not occur within 7 days after the initial dose and subsequent clinical assessment demonstrate that there is a high risk of preterm birth in next 7 days. Third option is antenatal corticosteroid is recommended for all LSCS in case of the late preterm and the term. Fourth option, antenatal corticosteroid is recommended for women at risk of late preterm and or IUGR from 34 weeks to 37 weeks of gestational age. So which are the option is right? I'm getting answer one from the B from Dr. Jaya. We are wait for the 30-second because it is not that okay. Some of the person is ABD Manjunath is waiting for the answer B. Okay. AB B. So we have 44 participants. I think we should. I was just waiting for other participant to give the answer. Okay, so 1 minute is over. So our answer would be A and B. So why is it not C? Because as per guideline, I think it is not beneficial when you give the steroid to late preterm and term baby in all LSCS. Although it reduces the hospitalization stay, but it increase the poor neurodevelopment outcome. So that's why it is out of question to give antenatal corticosteroid to all LSCS baby. Again, IUGR and preterm baby, there is a risk of the hypoglycemia and the neurodevelopment outcome. So that's why it is not recommended. So next question is a newborn term who born limp was started on bag and mask ventilation after initial step. After 5 breath, you notice that baby has no chest rise. Which of the following step is not important in managing the baby's condition? The A is ensure adequate seal. B. Clear the airway if secretion are present. Increase the oxygen concentration by adding a reservoir. Position of the baby's neck so that it is not overflexed or hyperextended. Waiting for 1 minute now. Excellent. So everyone is giving answer C. So it is the right answer. So if you see the MR SOPA, the M means mass adjustment, R for reposition. Again, you need to give a 5 breath, check for the chest rise. If it's not there, we need to suction the mouth and nose and open the mouth. And after that, we need to give again 5 breath. If it's not chest rise, then again we need to increase the pressure. Again, after 5 breath, if it is not chest rise, then we need to think about alternate airway. Excellent. So now third one is you are informing about the imminent delivery of 25 weeks of gestational baby. So what specific area of preparation will you concentrate? B. What specific measures you will take to minimize heat loss after birth? What action you will take to optimize the ventilatory support after birth? So there's a 3 question in that, and maybe there might be the overlapping answer. So what's the specific area which you think when you're dealing with the preterm baby? Hypothermia, yes. Then so there's a hypothermia. There other than hypothermia, CPAP, good. Perfusion, blender, clean wrap, gentle ventilation, excellent. CPAP. So you rightly said to prevent the hypothermia, we need to use the plastic wrap or either rewarming jelly. as we know, the blender is must when you taking the delivery of the preterm, because in less than 28 weeks we can't give 100% oxygen, so we need to start with 30% of the FiO2, and more than 28 to 30 weeks, 32 weeks, we need to offer 21 to 30%. Again, the gentle care is mandatory. Safe transfer with the incubator to prevent the hypothermia. And to prevent the hypothermia, do not dry the baby, wrap with the plastic, put in the radiant warmer. It automatically start humidification and prevent the hypothermia, and transfer if possible with the incubator. For the oxygenation and ventilation, early CPAP and blender is mandatory. So this is a 4 question. PO2 would be highest in which vessel? A. Fetal umbilical vein. B. Fetal ductus venosus. Fetal carotid artery and coronary artery. C. Fetal pulmonary artery. And E. Fetal umbilical artery. So which one has the highest amount of PO2? So everyone is writing A. Someone writing B. We'll wait for another 30 seconds. Yeah. So excellent. The majority is answer A, and it is right answer. As we see on the figure, the lung is not working when baby is in utero. So the most the oxygen is come from the maternal side. So once in the placenta, once it reaches to the umbilical vein, the saturation would be 80% and PO2 level is 30 mmHg, by which it travel to the liver and through the ductus venosus it reach to the foramen ovale, that means right atrium, and majority of blood will travel to the foramen ovale to the left atrium and left ventricle and systemic circulation. So if you see, when it reach to the umbilical artery, the saturation would be 55% and PO2 is 22%. That means in utero, the umbilical artery act as a venous system and the umbilical vein act as a arterial system. So next question is, this is we need to calculate. So please take out your mobiles and calculator. The following is the ABG of the child born by vaginal delivery with thick meconium stain lacquer and was non-vigorous at birth. At 6 hours on the ventilator, support of pressure of 3515, MAP of 17, FiO2 of 100, rate of the 60, and the saturation is 92%. And the pH at that time, pH 7.18, PO2 40 mmHg, PCO2 60 mmHg, bicarb 22.1, and base excess minus 9.6. So kindly calculate the oxygen index, means OI, oxygen saturation index, and alveolar oxygen difference, level difference. So by calculate this parameter, we can decide that this baby has a moderate or severe respiratory distress. So let's calculate one by one. So Aruna answered the OI around 42.5. OSI 18.47. Excellent, Dr. Jaya. So what is the OSI? Anyone knows the full form? Great, oxygen saturation index. Then what's the AADO2? Can anyone calculate? So I think most of people rightly said the oxygen index is mapped into FiO2 divided by PaO2. So 17 into 100 divided by 40 is equal to 42.5. So how did you calculate the alveolar and arterial oxygen difference? So you can know the arterial level by ABJ, but how can you calculate the alveolar level? The formula is 760 minus 47 is the barometer. It is a water pressure into FiO2 minus PaCO2. Now you can calculate the alveolar oxygen level. So any baby who is on the 100%, the FiO2 is 1. Any baby who is on the 50%, the FiO2 would be 0.5 for this formula. So can anyone calculate the alveolar oxygen level. PCO2 is 60. So what would be alveolar arterial oxygen difference? So 613, yes, excellent. So 613 is very high number. Anything more than 400 or 300 suggests severe respiratory distress, might be end up with the ECMO also. And again, OSI, everyone is rightly say, because now if anyone say that I have no ABGA machine, then definitely they can assess the respiratory distress by putting the formulation OSI. Now another calculation, calculate the calories of our 900 gram baby, 26 weeks, preterm baby receiving 120 ml per kg of the total fluid. Among them, there is a 2 gram per kg per day of fat to 3.5 kg per day of protein with 30% of the dextrose IV fluid. So how much calorie we are giving right now? We'll take another 1 or 2 minutes for that. So I give some hint. So for like for to calculate the fat, I think the formulation available in 20% means 20 gram in 100 ml. So we are giving 2 gram per kg per day. That means we are delivering 1 gram of the fat to this baby. For protein, 10% formulation is available in the market. That means 100 gram per 100 ml of protein. So by 3.5 gram, we are delivering the 3.1 gram of the protein to 900 gram baby. So we'll get the calorie from the fat and protein. And the 13% dextrose means 30 gram in 100 ml. So we need to calculate how much IV fluid we are delivering. We'll take 1 more minute. Let's see who can calculate the things. Still waiting for the answer. Okay, Dr. Jaya, write down 66 kilocalorie per kg per day. I think you are right. So let's calculate the things. So as I told, the fat is 20 gram per 100 ml. 1 gram of fat will deliver 9 calories. So it is fat contributed 16.2 calories, and the rate is 4.4 ml per hour. If you count the protein, 10 gram per 100 ml, so we are delivering 3.1 gram of protein, and each protein will deliver 4 calories. So total would be 12.6 calorie, and the rate is 1.3 ml per hour. We have to calculate the rate because we need to deduct from the total IV fluids. So as we know that the total rate would be 4.5. So we are delivering 2.8 ml per hour of the carbohydrate, which is into 24, 67 ml we are delivering to the baby. So if we calculate the calorie, it would be 35 calorie from the carbohydrate. To summarize, 63.7 calorie total, and when you divide it by weight, it comes with a 70.7 kilocalorie per kg per day. So nutrition is very important when you are dealing with the preterm baby less than 30 weeker. The ventilation is also, it is equally the ventilation. Any question on this one? Any confusion? Okay, let's go further. Identify this image and interpret. This is the image of one of the monitor, which I think most of center are using. Yeah, Dr. Jay, EEG. And what the interpretation? Okay, everyone know that the image is EEG, but what's the finding of this image? Okay, so the party said birth suppression, Elisa birth suppression. We'll wait for another 30 seconds. Dr. Jaya says encephalopathy. Navneet Patel birth suppression. Yeah, so it's a birth suppression. Why is it so? Because the lower limit is below 5 and upper limit also below 5. So if you see the normally, this is normal EAG, when where the upper limit should be more than 10 and lower limit should be more than 5. And this is a sleep wave cycle. Any baby who has a severe or moderate to severe HIE, then you can find a flat trace or birth suppression in which the upper limit is less than 10 and lower limit is less than 5. There's a one picture in between that one when baby is only moderate HI, in which you will get upper limit is more than 10 but lower limit less than 5. So this suggests might be the moderate HI, and this is the seizure activity. You can see there is a sudden rise of the upper and lower margin, and followed by there is between there is a decreased activity. This suggests the seizures activity. Okay. So this is a one case scenario. This is a 34 weeker, 34 plus 1 weeks, male, emergency LSCS for abnormal Doppler, no any antenatal corticosteroid, grunting and distress at birth. In NICU, baby is on 6 of PEEP and 40% of FiO2 on CPAP. X-ray and lung ultrasound as below. The question would be, should we give surfactant or should we consider a TTM? Because this baby is a late preterm. And if you see the X-ray, it looks like a HMD, am I right? And I will play for the the lung ultrasound video for a while. It is just stimulation. Just trying to do that. I think it's not working. So this is a lung ultrasound. You can see this is a pleural line, pleura, and this is a reflection of the pleural line. So this horizontal line we called as a line. Okay. Anyone can answer this one. What do you think? Does it TTN or does it RDS? Mayur said A line. Someone says RDS, RDS double lung point. Great. A line. Sliding of the lung. Yeah, it's present. Sliding of the lung is present. So majority of saying the TTN. Few of they are telling the surfactant should be given. Okay. So let's discuss it for 1 minute. So if in any normal lung ultrasound, the sliding through line with A line or margin in 1 or 2 separate B line is normal. But when you think about the TTN, there must be the spare area. That means you can see the A line. And if you think about the RDS, there would be no spare area and no L lines. So if you found the A line, any region of the lung while doing ultrasound, specifically the late preterm, where we are confused that should we give a surfactant to the late preterm or not, or should we consider the TTN? In that case, the lung ultrasound is very useful. And we considered this baby as a TTN, and baby was on the CPAP for 48 hours and it come off by its own without surfactant. So this is a picture between TTN and the RDS. So this is one baby which we received recently last month. Is a A line. We haven't given the surfactant. And this is another baby we received after a few days with the same gestational age and lung ultrasound showing the confluent B line. So there is no A line. So in RDS, always remember there would be the homogeneous picture. You can't find the spare A area. There's another question. In which condition prostaglandin E1 is absolute contraindicate? A. PDA with the right to left shunt. B. PPHN. C. TGA. D. TAPVC. And E. None. So which are the contraindication for prostaglandin? So everyone saying a D. We'll wait for another 30 seconds. TGA someone saying D. On one person saying only intracardiac TAPVC. It's contraindicated. Okay. Someone saying A. PDA with the right to left shunt. Manjunath A. Okay, Mayur saying E. Okay, so answer would be E. Mayur said rightly because I know the TAPVC is a contraindication, but it is a relative contraindication. If any baby you are suspecting the congenital heart disease, drug dependent, you can start prostaglandin E. At same time, baby is not going to deteriorate like within a second. If you feel that baby has a prostaglandin E and when you start and baby has a more cyanosis, then you need to suspect the TAPC and at that time we need to stop the prostaglandin E1 because it ultimately increase the right to left shunt, pulmonary congestion, more mixed blood is going from right to left side and that's why the this cyanosis is aggregated. So the answer would be none. Of course, the relative contraindication is TAPVC. Okay, in which condition therapeutic hypothermia not contraindicated? A. Major congenital and genetic abnormality. B. Severe coagulopathy beyond 6 hours of life. And D. Severe PPHN. So, which are the condition in which the it is not contraindicated? Mayur say T. Navneet D. We'll wait for another 30 seconds. Someone says none. Dr. Pamela D. Bharti D. Rahul D. Alisa D. D. Chandu is saying D. Any different answer apart from D? Arvind saying C. So question we need to read the question rightly. Not contraindicated means which are the indication. The right answer is the severe PPHN because in major congenital anomaly we can't offer the therapeutic hypothermia. Again, same situation with therapeutic coagulation. No any role of therapeutic hypothermia beyond 6 hours of life. So you can start the therapeutic hypothermia in severe PPHN with the nitric oxide also. In some of the cases, if it is worsened, then we need to think about to stop the therapeutic hypothermia. Otherwise, it is a not a absolute contraindication in case of the severe PPHN. Any query, guys? Anyone, any query on previous examination or any case? I'm happy to answer. Thank you.